Usually, when we talk about a medical diagnosis, there's this expectation of precision, right? It's almost like engineering.
Yeah, exactly. You break your arm, you get an X-ray, and there's that jagged white line.
Right. And as the surgeon, you just you point at the screen and say, well, there it is. That's the problem.
Right, it's totally binary. Like, it's either broken or it's not. The pathology is just undeniably there.
But then, you step into this world of chronic pain and nervous system dysfunction, and suddenly that X-ray machine is just absolutely useless.
Oh, completely useless. The whole diagnostic landscape gets incredibly murky.
Which is exactly why today's deep dive is dedicated entirely to complex regional pain syndrome, or CRPS.
Right.
Welcome to this revision deep dive. This is designed specifically for you, the resident preparing for board exams like the FRCS and plastic surgery. We're skipping the banter today and just getting straight to business.
Definitely, there is a lot of ground to cover.
But before we jump into the clinical criteria, just a quick requirement. Hit the follow button right now to ensure you hear more of these revision deep dives. And please rate the show if you learned something valuable today.
Yeah, it really helps.
Also, you need to get a premium subscription to listen to the Journal Club and Clinical Cases episodes. That is absolutely essential for your exam prep and, frankly, for surviving the Viva.
I highly recommend it.
So let's unpack this. We are plastic surgeons, right? We specialize in anatomical reconstruction, moving tissue from point A to point B.
Right.
Why on earth do we need to master a murky, neurologically driven pain condition like CRPS?
Well, because before we can even attempt to diagnose CRPS, we really need to understand the clinical context where it most commonly, ambushes our post-op patients.
Ambush is a good word for it.
It is. This isn't just some niche neurological issue that you can just refer away and forget about. It's a direct occupational hazard of the procedures that plastic and orthopedic surgeons perform every single day.
All right, in our backyard.
Exactly. I mean, if you look at the general epidemiology, the incidence varies from about 5.5 to 26.2 per 100,000 person years.
Okay.
And notably, females are affected 3 times more frequently than males.
Okay, but those are the general population numbers. When you're sitting in the exam room, the examiners, they want the high-yield statistics related directly to surgical interventions, don't they?
Oh, absolutely.
Yeah.
They want to know what happens after our bread and butter procedures.
Right. So what are those numbers?
The numbers there are completely staggering, honestly. For instance, CRPS affects 4.5 to 40% of patients after Dupuytren's fasciectomy.
Wait, 40%. Let me just pause on that, because 40% is a massive number for a procedure that is so incredibly common.
It is massive. It's almost half in some studies. And moving on to other routine surgeries, it affects 3.2 to 5% of patients after carpal tunnel decompression.
Okay, still significant.
Yeah, and it affects up to 28% of patients after distal radius fractures.
Wow, 28%.
Yeah, and what's really fascinating about that last statistic is the anecdotal association.
Which is what?
Well, that high incidence after distal radius fractures is frequently associated with an overly tight cast.
Okay, here is where we need to talk about the mechanism.
Yeah.
Because this is where the logic just seems to completely break down for me.
How so?
We're talking about a routine carpal tunnel release, or simply a cast that is put on a little too tight, right? And that leads to a debilitating, life-altering chronic pain condition.
Yeah, it sounds crazy.
The literature explicitly states that the inciting injury, quote, need not be severe. It feels like a tiny spark causing a massive, uncontrolled forest fire. How does that actually happen?
Well, that's the defining paradox of CRPS, and it's exactly what you need to understand for your exams. The severity of the initial injury simply does not correlate with the onset or the severity of the syndrome.
So a huge injury doesn't mean huge CRPS risk.
Right, you could have a devastating, multi-tissue crush injury that heals predictably and perfectly. But on the flip side, a minor sprain or a routine fasciectomy can spiral into that massive forest fire you just mentioned.
So the injury itself isn't the actual disease.
Precisely. The inciting event, whether it's the surgery or the tight cast, is just the key turning in the lock.
Okay.
The nervous system's disproportionate response is what actually burns the house down. Think of it like a car alarm that gets triggered by just a gentle breeze.
Okay, I like that analogy.
But the siren is so loud that it vibrates the car, which triggers the alarm to ring even louder, which vibrates the car more.
So it's feeding itself.
Exactly. The nervous system gets caught in this closed feedback loop of panic, firing pain signals, long after the original minor threat is totally gone.
Wow. So what does that forest fire actually look like when the patient walks into your clinic? Because as a resident, you need to recognize this immediately, right? Before it becomes entrenched.
Yeah, early recognition is key. The most prominent symptom is continuing pain.
Hmm.
But this isn't just standard post-op soreness.
Right, it's different.
Very. It's intrinsically associated with severe limb dysfunction and profound psychological distress. The psychological component actually gets incredibly strange very quickly.
Strange how.
Well, patients will often present with what we call neglect-like symptoms.
What does that mean in practice? Like they're just ignoring the hand?
Much deeper than that. They might describe feeling that their own limb is entirely alien to them.
Alien. Like it's not theirs.
Exactly. They feel a complete cognitive and emotional disconnect from their own anatomy.
That is a massive red flag. If a patient tells you their hand doesn't feel like it belongs to their body anymore, you have to be on high alert.
100%.
And alongside that psychological presentation, what are we looking for objectively on the physical examination?
You must examine for specific trophic changes. This means looking at how the tissues are actually growing and maintaining themselves.
Okay, so what do we see?
You'll see noticeable stiffness and edema. You will see osteopenia on the x-rays.
Right.
And you're also looking closely at the surface. You might see atrophy of the hair, the nails, or the skin itself.
Just wasting away.
Yeah. Or, alternatively, depending on the phase of the condition, you might see the exact opposite on the skin.
Which is?
Hypertrophy, specifically hyperkeratosis, where the skin becomes abnormally thickened and scaly.
Oh, wow. Okay. Now, when we classify this condition, the literature divides CRPS into two distinct types.
Yes, types 1 and 2.
Right. So type 1 occurs in the absence of a lesion to a major nerve. Historically, you might hear older attendings or read older textbooks referring to type 1 as reflex sympathetic dystrophy or Sudex atrophy.
Right, those are the old terms.
And then you have type 2, which occurs in the presence of a confirmed structural lesion to a major nerve. This was formerly known as causalgia.
Exactly.
Let me push back on this classification, though.
Mhm.
Does differentiating between type 1 and type 2 actually change our core management plan? Or is this just academic taxonomy that we have to memorize for the boards?
Well, it's definitely a critical distinction for your exam, so you absolutely must know it.
Right, but practically speaking, in the clinic.
In the clinic, aside from the fact that you must clarify the nature of the specific nerve lesion in type 2, and obviously treat that lesion anatomically if required, the overarching management of the CRPS itself remains exactly the same for both types.
Okay, so the car alarm is treated the same way regardless of what tripped it.
Exactly. The underlying syndrome, that feedback loop, is treated identically.
Okay, so to accurately document these features, and frankly, to survive the Viva portion of your exams, you must master the precise vocabulary of pain.
Yes, terminology is everything here.
You cannot afford to mix these terms up when an examiner is drilling you on a clinical scenario. So let's not just list these, let's apply them. I'm going to throw out a clinical situation and you give me the exact terminology.
Let's do it.
Okay, baseline definition first. What is the strict definition of pain?
Pain is defined as an unpleasant perception associated with actual or potential cell damage.
And analgesia.
That is the absence of pain in response to an insult that absolutely should produce pain.
Okay, here is where it gets tricky for residents. Paresthesia versus dysesthesia. Let's say a patient says their hand feels like static electricity, just tingling. Not necessarily hurting, just abnormal.
That is paresthesia. It's a spontaneous, abnormal sensation.
But what if they say that static electricity feeling is deeply uncomfortable, distressing, and painful?
Then it crosses the line into dysesthesia. It is an unpleasant, spontaneous, abnormal sensation.
Unpleasant being the key word.
Exactly. The distinction you need to articulate in the exam is the unpleasantness.
Got it. Okay, next pair. Allodynia versus hyperalgesia. We really need to firmly separate these.
Very common Viva question.
Right, so let's say I'm examining the patient's hand. I take a feather, or just the light touch of my gloved finger, and I brush it across their skin. A completely harmless stimulus. But the patient screams in agonizing pain.
That is allodynia. It is the perception of a non-painful stimulus, like the feather or the light touch, as painful.
Even though it shouldn't hurt at all.
Right. The stimulus shouldn't hurt, but the brain interprets it as damage.
But what if I take a standard neurotip pinprick to test sensation? It's a sharp pin. It's supposed to hurt a tiny bit. But instead of a wince, the patient has a massively exaggerated, disproportionate pain response and pulls their arm away in absolute agony.
That is hyperalgesia.
Mm.
It's an increased, exaggerated response to a stimulus that is normally painful. The pinprick should hurt a little, but it hurts entirely too much.
You got it. Feather-causing pain is allergesia. Pinprick-causing massive pain is hyperalgesia. What about hyperesthesia?
Hyperesthesia is an increased sensitivity to a non-painful stimulus.
So it's like an umbrella term.
Exactly. It encompasses both allodynia and hyperalgesia as a broader category of heightened sensitivity.
And hyperpathia.
That is an exaggerated and very painful response to stimulation, often where the pain persists and radiates even after the stimulus is removed.
So it lingers.
Right.
Finally, neuropathic pain.
Pain initiated by a direct lesion or a dysfunction of the peripheral or central nervous system.
Perfect. So, armed with that exact terminology, how do we definitively lock in the diagnosis? Because as we said, there is no blood test for this. There's no MRI that flashes red and says CRPS.
Right, exactly. The diagnosis is based on clinical criteria alone. In the UK, guidelines rely strictly on the Budapest criteria.
Okay, Budapest criteria.
This is extremely high yield for your exam. To diagnose CRPS, a patient must meet 4 distinct criteria.
Build a clinical picture. Criterion 1.
Criterion 1 is the fundamental baseline, the presence of continuing pain that is disproportionate to any inciting event.
So the pain outlasts the expected healing time of the fasciectomy or the fracture.
Does that make sense?
Exactly. Now, criterion 2 requires the patient to report at least one symptom in 3 of the 4 following categories. And this is where we really have to understand the why behind the symptoms.
Yeah. So category 1 is sensory. The patient reports hyperesthesia or allodynia.
Okay.
Category 2 is vasomotor. They report temperature asymmetry or skin color changes and asymmetry.
And why does this happen?
Because CRPS is largely a sympathetic nervous system misfire.
Right.
The nerves controlling the blood vessels are malfunctioning, dilating or constricting improperly, which is why one hand might be hot and red while the other is cold and pale.
Oh, that makes total sense. And that perfectly explains category 3, pseudomotor or edema. They report edema or sweating changes and asymmetry.
Yes.
Because again, the sympathetic nervous system controls the sweat glands. If the system is in overdrive, that hand is going to sweat abnormally compared to the healthy side.
Exactly. And category 4 is motor or trophic. They report a decreased range of motion, motor dysfunction like weakness, tremor, or dystonia, or those trophic changes we mentioned earlier to the hair, nail, or skin.
Okay, so just to recap, they must report a symptom in at least 3 of those 4 categories.
Correct. 3 out of 4.
Which brings us to criterion 3. This shifts from the subjective symptoms the patient reports to the objective signs you, the clinician, observe at the time of evaluation. They need at least one sign in 2 or more of those same categories. Wait, hold on. Let me stop you there.
What's that?
So the patient has to report symptoms in 3 out of 4 categories, but I only need to visually observe signs in 2.
No.
Why the mismatch between what they feel and what I have to see?
That's a great question. It's because CRPS fluctuates. What the patient experiences at home on a Tuesday night might not be actively flaring up while they're sitting in your exam room on a Thursday morning.
Ah, okay. That makes sense.
Yeah, the criteria account for this temporal fluctuation. But you still must document what you see. So for sensory, you find hyperalgesia to pinprick, allodynia to light touch, temperature sensation, deep somatic pressure, or joint movement.
And for vasomotor, you objectively measure a temperature asymmetry of greater than 1 degree Celsius, or you directly observe those skin color changes.
Exactly. For pseudomotor or edema, you observe the swelling or the sweating asymmetry.
Right.
And for motor or trophic, you observe the decreased range of motion, weakness, tremor, dystonia, or the physical changes to hair, nails, or skin.
And finally, we have criterion 4. No other diagnosis better explains the signs and symptoms. I have to challenge this one, though.
Go for it.
When you're sitting in the exam room and the examiner asks you about this, how do you avoid the trap of just using CRPS as a convenient wastebasket diagnosis?
It's a risk.
Right. It sounds entirely too easy. If you simply don't know why a patient's hand hurts 3 months post-op, you just shrug and write CRPS in the chart to explain it away.
That is a very common pitfall, and examiners love to test your discipline on this. You avoid the wastebasket trap by strictly enforcing criteria 1, 2, and 3.
You can't just skip them.
No, absolutely not. You do not just diagnose CRPS because the pain is mysterious or annoying. You diagnose it because they specifically meet those exact symptom and sign thresholds across the sensory, vasomotor, pseudomotor, and motor categories we just outlined.
So if they don't hit the marks,
If they do not hit those precise Budapest criteria markers, it is not CRPS. You need to keep looking for a neuroma, an infection, or a non-union.
okay. So Once those rigorous Budapest criteria are met, and we are certain it is CRPS, how do we actually treat it? We're talking about an idiopathic condition. The textbooks clearly state there is no medical cure.
Which means our strategy shifts entirely to management and the prevention of sequelae. Early diagnosis and early movement are absolutely paramount
It
here.
prevents stiffness and stuff?
Yes, to prevent the secondary problems of disuse, like contractures, and the profound psychological consequences of undiagnosed chronic pain. Ideally, these patients are best managed in specialist pain or rehabilitation clinics.
Right.
The multidisciplinary treatment is built on 4 pillars of intervention.
Let's walk through those pillars logically. You can't just jump into aggressive physical therapy if the patient is terrified and in agony. So the foundation, pillar number 1, has to be patient information and education.
This is all about validation. You must provide reassurance that CRPS is a formally recognized medical condition.
It's a real thing, you're not crazy.
Exactly. Crucially, the patient needs to know that this is not an indicator of substandard surgery. It is a biological response, a misfiring of their own nervous system.
Right.
You also educate them that the symptoms are usually transient and tend to respond well to physiotherapy.
So once they understand what's happening, we move to pillar number 2, pain relief. But the goal here isn't just to make them comfortable so they can sit on the couch and watch TV, right?
Not at all. The entire functional aim of pain relief is to support the exercise and therapy program. If you don't control the pain, they cannot move the limb.
Simple as that.
Yep. For trauma-related pain, you utilize paracetamol, cocodamol, or NSAIDs. You should also consider neuropathic medications like amitriptyline or pregabalin to really calm down that nervous system misfire.
What about opiates? Because we established this pain is agonizing, sometimes worse than the initial injury.
Avoid opiate analgesia completely.
Really? Complete.
Unless you are specifically advised to use it by a specialist pain clinic, opiates are generally ineffective for this specific type of neuropathic feedback loop, and they carry massive risks of dependency.
Good to know.
There is another intervention to note here for your exam, pamidronate.
Oh, right.
It may be given as a single intravenous dose within 6 months. We know it limits the osteopenia associated with the condition, but fascinatingly, its actual mechanism of pain relief is currently not known.
Magic of medicine. So we've educated the patient, and we've chemically dialed down the pain. That allows us to move to pillar number 3, physical and vocational rehabilitation.
Yes.
This places the emphasis on restoring normal function through goal-based exercises. This might involve desensitization exercises, right? Like rubbing different textures on the skin to retrain the brain's interpretation of touch.
Exactly.
It also includes mirror visual feedback, which essentially tricks the brain by letting it watch the healthy limb move in a mirror, rewiring those distorted sensory maps of the affected limb.
A really fascinating technique.
But here's the most critical rule. The text explicitly states to avoid slings and splints. This feels incredibly counterintuitive.
I know.
If the arm is in excruciating pain, shouldn't we immobilize it to let it rest? It's like telling someone with a severe leg cramp that they have to immediately sprint.
That is the exact instinct you have to fight, and it's why this is such a frequent board question. Immobilization is the absolute enemy of CRPS.
Because of the car alarm thing?
Remember the car alarm metaphor. If you put that limb in a sling or a splint, you are directly fueling the cycle of disuse. Disuse worsens the trophic changes, increases the stiffness, and amplifies the brain's alien limb perception because the limb is being hidden away and ignored.
So they have to use it.
They must keep moving it to break the feedback loop, no matter how counterintuitive it feels in the moment.
Which perfectly segues into pillar number 4, psychological intervention. You cannot force a patient to move a limb that is causing them agonizing pain without addressing their mental state.
No, you can't. You must manage the associated anxiety and depression that inevitably comes with chronic pain.
Right.
This also involves the exploration of external influences or perverse incentives.
What does that mean, perverse incentives?
Clinically, this means asking, is there an ongoing litigation, a lawsuit, or a compensation claim that might unconsciously be affecting the patient's recovery?
Oh, wow.
Yeah. If they are financially disincentivized to get better, rehabilitation becomes nearly impossible.
That's a really good point.
And finally, cognitive behavioral therapy, or CBT, is utilized to provide vital coping strategies.
Okay, so we have the progressive logical steps. Education, pain relief to enable movement, rehab without splints, and psychological support.
These are the 4 pillars.
But what happens when those pillars fail? we have to discuss the refractory cases and the ultimate prognosis.
For non-responders, the escalation of care includes topical lignocaine, capsaicin patches, and guanethidine sympathetic blocks.
And those blocks are to, what, chemically interrupt that sympathetic overdrive.
Exactly.
And as surgeons, we're trained to operate. When do we go back in to fix the nerve or clean up the scar tissue?
We don't. Surgery is strictly avoided.
Avoided.
Completely. Operating inflicts an additional, massive, painful stimulus, which is exactly what triggered the syndrome in the first place.
Oh, of course.
Yeah, you will only throw gasoline on the fire and make the CRPS infinitely worse.
So what is the timeline we are looking at for these patients? What do we tell them about the future?
For most patients, CRPS is transient. It lasts up to 18 months with proper management.
Okay.
However, the exam will want you to know the outlier statistic. 15% of patients will have unrelenting pain and physical impairment extending beyond 5 years.
Wow. 5 years.
Yeah.
I want to end on the ultimate extreme here, building on that 15%.
Okay.
If you have a patient suffering unrelenting, debilitating headache for 5 years, the limb is contracted, useless, and the pain is destroying their life, why not just amputate? Why not just remove the source of the pain entirely?
Because amputation is absolutely not a treatment for CRPS.
Even in the worst cases.
Even then, if you amputate the limb, the symptoms often just recur as phantom CRPS.
Wait, really?
Yes, the pain doesn't live in the hand anymore. It lives in the nervous system. Amputation is only ever considered or necessary in the case of a life-threatening infection.
I want you to really ponder that terrifying reality as we wrap up this revision session. The nervous system's grip on this pain condition is so profound, the dysfunction is so deeply wired into the central circuits, that even removing the limb entirely doesn't remove the disease. The ghost of the limb continues to burn.
It's incredibly sobering.
It is. We started this deep dive talking about how much we love the clarity of an X-ray, the visible proof of a broken bone. CRPS is the ultimate reminder that the most devastating complications you'll face in your career won't show up on a scan at all.
Absolutely true.
Before you close your notes and go study, drop down to the comment section and leave a comment or a specific question about what we discussed today.
We'd love to hear from you.
Engaging with the material directly, challenging the criteria, is the absolute best way to solidify your exam revision. Keep studying, and we'll see you on the next deep dive.